there are overlaps in these three buckets, but generally what type 1 evidence is sort of this evidence of etiology and burden. So, I use an example, what, does smoking cause lung cancer? And we know it does. And what's the burden of lung cancer in a population? So that tells us we've got a problem. It doesn't tell us anything about what to do about smoking. So type 2 evidence is intervention evidence. So that is, if I want to take on smoking as an issue, a clinical issue or a public health issue, do I follow community preventive services guideline? Do I follow the community guide? For smoking, we've got as long a list as probably any other public health issue about what those effective interventions are. We have probably a secondary amount of that kind of evidence, certainly not as much. One time when I used to do I did lung cancer research in Colorado for my doctorate. And at that time, I think there were somewhere between 10 and 15,000 published studies on smoking and lung cancer in the literature. So you sort of think, well, do we need any more type 1 evidence on some of these? The answer is resounding no. At that point, there was relatively little of the sort of intervention evidence. But now, 20, 30 years later, there's a lot of intervention evidence for a lot of the work that you all spend your time on. Type 3 evidence is this sort of more relevant to D&I. So that's dissemination. So if you have an effective intervention, how do you disseminate it? How do you implement it? How do you take context into account? And that is by far the least type of evidence we have. It tends to be a little bit more qualitative usually, although it's getting a little bit more quantitative all the time. And so while we kind of cover all three of these briefly in the paper, we're focusing primarily on the things that would extend that idea of type 3 evidence. So Russ, let me stop there. That's sort of the backdrop for some of the broad definitions. Anything else to add in that first part?
For once, no, I don't think I do have anything other than we should just note this was Ross's brainchild, but our co-authors have it on there. But if you haven't had a chance to look, are Rachel Shelton, who's added a lot from health equity, no surprise, perspective, and then Elvin Gang, who's a very intriguing colleague of Ross's. And Ross, you might want to just say a word about Elvin, since I don't think most of the group will know him.
Yeah, Elvin's an HIV doctor, so he's done almost all of his work around HIV and infectious diseases, and he does a lot of his work in Africa on HIV and a lot of those challenges. And so while he's been, living in the U.S. in different places, and we recruited him here a couple of years ago because we were frankly really weak in infectious disease and D&I research, and so he's really built that up, and so he brings in a lot of those concepts from sort of moving evidence out of what are typically pretty high resource settings, or at least let's say middle to high resource settings in the US, to some very low resource settings in lower and middle income countries, in his case, in different parts of Africa. And so he added a lot to the, you'll see when we'll once we get the paper to a kind of an acceptable stage, we'll send it around, maybe revisit some of this when it's in a final form. But he added some really good ideas and examples around some of those issues, and the issues like transportability, and when do you need to study something in a certain context, or when do you just do it because the public health issue is so pressing. So that was the piece. So then the sort of, as we get into looking at these recommendations, there are sort of 5 domains that we build out, and some of these are going to be things like a number of you have already worked on. So I thought I saw Roger. Yeah, so Roger Kessler has written and talked a lot about sort of this randomized trial issue. So the first issue we talk about is to reconsider how the evidence base is determined. And so in that, part of that focuses on what we typically have is this sort of over-reliance on randomized trial, and we're not going to throw out the baby with the bathwater. We're going to certainly use a randomized trial when it's called for. But as you all well know, there are many examples where a randomized trial isn't really a fit. If you take policy and policy interventions, for example, you really can't do a randomized trial for many policy related things. So some of that is sort of thinking more broadly about the randomized trial, or applying tools like PRECI, where you might be doing a very rigorous sort of study design, but you might be thinking about a larger set of contextual issues as you're implementing it. And so we bring that into some of the discussion. We begin to think about sort of some of these issues. This sort of, do you start from scratch? Every time you're moving into a new setting, a new context, you would do some sort of adaptation. And as you know, there are a lot of frameworks now. Frame is one sort of adaptation framework, the Frame IS, which is newer, and then Adapt. So there's a number of these different frames and frameworks that will help us in adapting. And then we've talked a little bit around the evidence base about how we might learn from null interventions. You know, what we tend to write about and what we tend to get published are the things that show an effect. And a lot of times we don't tell the story about things that didn't work out the way we thought they had. So we talk about that. We briefly talk about the understudied areas of de-implementation, or something that we're working on now in public health we call misimplementation, which is sort of two parts of implementation. One is you've got something that's effective and you're not doing it, or you've got an ineffective intervention and you're doing it and you got to stop. Sort of that's the de-implementation part. And we've got a project now where we're modeling that, but there's very little of a broader evidence base around a number of those issues. The second bucket of what we talk about is one that won't be any mystery to you, because I know you talk about it a lot and work on it, is the idea of context and the context for implementation. So we go through a long list of potential contextual variables across an ecologic framework from the individual all the way down to the community and policy. And we sort of outline those. We talk about ways of studying context. And then in particular here is where some of the global considerations come into play. You know, how do you work with studying context in settings where you don't have a lot of the data systems in place? Or when do you even know when something is ready for a D&I study? And a lot of that relates both to the evidence base and to context. And then this is another point where Elvin brought in the idea of transportability theory and looking about how something works in one setting and how it can be moved to another and whether it's likely to work. And that's something that they use quite a bit in the HIV world. The third bucket is one around equity and health equity. And here we start with sort of the premise that it is an understudied area. We do a little bit of looking at with a simple sort of PubMed search from the year 2000 to 2021. And we search the strings of health disparities and health equity. And what's interesting here is health equity basically doesn't appear in the literature in the early part of this, or very rarely does it. Health disparities is the framing that's much more common. And then it sort of flips in recent years. And the way a lot of the scholars in this field look at it is health disparities is sort of looking at what's going wrong, and health equity is looking at sort of the solving. So it's sort of a framing of things. And health equity is generally taking a broader view of all these contextual variables and all the different things that will impact on sort of leveling the playing field for different settings and different populations. And so this is the part that Russ mentioned that Rachel Shelton helped us build out. And the underlying, I would say our underlying premise for this thinking is that equity should be a core criterion for valuing evidence. In other words, we'll argue that every study ought to take equity into account in some form or another. At a minimum, it ought to look at doing no harm. In other words, there are a number of interventions and policies that, when implemented as developed, will make disparities worse or make inequities worse. And so at a minimum, it's sort of do no harm. But on the other side of that is to really, in a more intentional way, in designing a study from the start, is make equity part of that. And so what we build is then some of the, what are the evidence issues that come into play when you're trying to focus more on equity. And I'll just keep rattling along, Russ, and then I'm going to ask you to chime in on any of these 5 areas, okay?
I think we're good, but again, as you said before, just others feel free to jump in if you want here too. Ross, we're just kind of walking you through the buckets. I think Ross has just 2 more, then we'll definitely pause and take comments and then go to the table. but I think you're on a roll. So keep going.
Okay. I don't really like to hear myself talk, so I'm going to probably talk more quickly. So the fourth area is this area of policy implementation and evaluation. We, several of us on this paper work quite a bit in this, and there's clear, if you sort of juxtapose the impact of policy on people's lives and the amount of policy D&I research that has been funded and published, there's a pretty big difference there. So there's a sort of an open playing field for policy implementation research. And it's also an area where we really benefit from getting outside our own silos in medicine and, you know, physical therapy and public health, because we can learn so much from, you know, disciplines like policy and political science, and you name the sector, there's a lot to be learned from other areas as well. And so we sort of set that up as an area that is in need of a lot of work. It clearly sort of relates back to the equity issue as well, because a lot of what you look at in these policy studies is trying to get more at the upstream factors that lead toward inequities. And this also gets back to some of the designs and the ways that evidence is developed, in that a lot of these policy studies are not going to be done through the usual randomized trials. And so, you know, some of this we're hoping gets the study section, so that if a study section gets a hold of what we would call a big P policy study, which would be sort of the official policies of government, or a small P policy studies, which would be things that go on in a clinic, in an organization, that aren't driven necessarily by a government. It might be driven by professional standards, that we take a clear look, that we don't just automatically default to that study has to do a randomized trial or it's going to get knocked down. And so we're hoping some of this will get to that. And then the last area is what we call adding greater attention to audience and stakeholder differences. And this comes into play where we start to think, this is a little bit of the designing for dissemination work. I don't see Bethany on here today, because Bethany's been leading with others there at your group, leading a lot of this work. But this is thinking about, how do we think about who would benefit from something? How do we think about principles like audience segmentation, where how we're taking evidence and turning it to a certain audience who are not typically, even people who are working in our fields, even public health practitioners and clinical practitioners, our coin of the realm tends to be the journal article, and that's not typically how different audiences find and receive evidence. And so thinking about what we can learn from things like marketing and social sciences around the differences that stakeholders take when they look at a body of evidence. And so we outline 3 core groups, or 3 core audiences: researchers, practitioners, and policymakers. And we do our sort of back of the envelope about the similarities and differences around those, especially how it relate to how they find and use evidence. And so I think that's it. And so there's other pieces of this thing, but those are the main parts. And so Russ, let me stop and then see if you have any comments, and then I'll take a look at the chat, and then we'll also then show at least the main pieces from the table.
Yeah, no, I think we're good so far, and I think maybe Victoria, you can go ahead and share the table and see about comments. But let's do pause here, just see any general initial reactions people have, and then we'll get a little more concrete and take, as Ross said, this is kind of a exhaustive table that we hope you won't go asleep by the time you get through it, but we can maybe take it a page at a time or something. So it does have a lot of different things in it, but let's just pause for any initial reactions. And also, frankly, what would help us the most is if there's anything that you either disagree with or think is a faulty argument, or you find a hole in, or that just really is something we're likely to get a lot of pushback on, that we'd frankly appreciate that as much as anything. So.
Yeah, I think especially if there's things that you think when you work with evidence or you review grants that comes into play. Jody, I think I saw your hand, did I?
Yeah, my question is, so we have the table and the abstract, but not the rest of the paper. But is your intent with writing this to encourage people to think differently about evidence, or to say where there are gaps in evidence, or both, or something else?
Yeah, I think it's really both. It's a really good question. I think it is sort of taking on what we think are some of the sort of standard views of evidence. You know, like, so I'll give you an example. So in my world in epidemiology, I don't think a lot of people who spend their lives studying type 1 evidence would even agree with me that in many areas of health, we have enough type 1 evidence. We need to move on. We need to. So part of it is trying to get people thinking about, for some audience, even introducing the ideas of this sort of D&I kind of evidence. So showing some of the gaps, taking on some of it is, we also provide a fairly long table about resources that are out there. So if you kind of think about these 5 kind of big buckets that I just talked about, if I wanted to learn more about how do I adapt evidence from one setting to another, what are some tools out there? And I think we defaulted mostly, Russ, to freely available tools, not things that you have to go and buy. And so we wanted to kind of open up some of the access as well. Jody, one of the big questions we had when we were putting this together is, do we kind of write this for implementation scientists, or do we try to get it out to a broader group? And we decided, just because it was written so much in the language of implementation science, that we submitted it to the journal Implementation Science. But I think one of the things we need to do with this is get it outside of just the people who already know a lot of this stuff.
Yeah, because it kind of seems like the 3 categories of the type 1, type 2, type 3 encourages people to think about evidence differently, that it's not just this type 1, you know, but then the table seems like it's more, maybe I'm not reading it correctly, but here's where there are gaps. Like, it just kind of seems like they're kind of 2 separate things a bit, like, because I don't know, like, I think health equity is super important, probably the most important thing that we could be doing, but it seems like the popular thing to throw in there right now, you know? Yeah. So you really want to make the argument for why, you know, and is that a different way of thinking about evidence, or is that just that we are lacking the kind of evidence that we need, and that, you know, because a lot of studies don't take that into account, and we don't know about different populations because we haven't studied them and included them, you know? So I'm just kind of trying to think about how to wrap my head around that, you know, I don't know. That's just my reaction. Yeah,
no, it's a great point. And it's sort of, this is one of those where you remember this outline, because I think you were on the call when we looked at that longer outline. We had even more stuff in that outline. So it may be true that we just didn't narrow it down enough yet. And so we probably will hear back about that.
Well, I mean, like, some people could argue that health equity would be kind of part of context, like the context of the people you've included, or that it might be part of audience differences, or, you know, like why the groupings are that you have. I mean, I think they're really good points. It's just, are they all the same kind of thing, or a different thing, or?
Yeah, I think it's a good point. It's a good point. Any other kind of bigger picture questions before we sort of scan through what are these recommendations?
I have one real quick. One of the papers of yours, Ross, that I reference the most is the Designing for Dissemination. Mm-hmm. And there's something about intervention design and what is the best evidence for intervention design. It seems like a lot of times we talk about evidence or research, we kind of talk about it after the intervention has been developed. But I think we fall down a lot at the moment of intervention development. Mm-hmm. So then, like the decision aid world where I work, where there's a lot of decision aids that have all these efficacy trials that no one uses. And I don't know, it kind of relates to adaptation, and I like some of this stuff here around, implement alternatives and modifications. But I wonder if there's room for a discussion about what does evidence-based medicine at the design of intervention phase look like. Mm-hmm. I don't know if it fits in here, but that was just one thing, if you're looking for brainstorming, that crossed my mind.
Yeah, that's great. And Russ, I don't know, I think Bethany's paper is officially out now. If you haven't done a session on D4DS, so Bethany led this review, Designing for Dissemination and Sustainability. And it's actually a much better take on a lot of the stuff we started writing about 8 or 9 years ago. So if that might be a great topic for a future meeting, and now that paper I think officially is, if it hasn't been posted on the website, it'll be posted really soon. I think it's fine to share that now that it's come in the final proof stage.
Right. In annual review of public health,
Yeah.
which if you don't look at that religiously, Ross won't talk to you anymore. So that in mind. Dan, your point, I think, is a really good one. And it also, maybe it's a bit of a force fit, but I think at point 3 here, if you can look at the table there, in terms of the pace of evidence development, to me, the general notion here, and that we talk about this in the text, but is just more the speed too, and having much more rapid evidence there. And I think that's part of it. That starts with the development phase, and again, as you and others, and there's a lot written about various types of centered designs and things there to do that much more rapidly. But I think you could also argue that not only the initial development, but doing that in a way that's stakeholder engaged and rapid and iterative will shorten the entire cycle, even during the evaluation, and you'll be much more likely to end up with something that then can be translated to if we do that type of development.
Great. So,
anything else just in general or on this page? And then I've asked Victoria to kind of use her judgment, but there's 4 pages of this table to kind of scroll through. But before she goes to the next page, this one was on evidence, and then the next one, it goes on these buckets, is largely on context. But is there anything else on this page people would like to comment on?
I was wondering, for this table, is it just supposed to be focused on that type 3 evidence for dissemination and implementation, or is it supposed to inform all types?
It's probably, I would say it's primarily the type 3 bucket, but there is this sort of what Jody was, there's so much overlap between these. So for example, in the health equity bucket, if you're thinking about type 2, so is an intervention effective, a clinical intervention or a broader public health intervention, that might start out as a type 2 question, because we might say, well, we have pretty good evidence in this middle or higher resource setting, and now we're exporting it to a setting with health equity challenges going on. And so that's where these sort of type 2, type 3 sort of merge. I would say it's generally around this, it's very little about the type 1 group, although there's even some of this. So I think there's an example in there around audit and feedback. And you could argue some of the data, some of the basic data about use of a practice, the burden of something and use of a practice. You could even argue that might be type 1 evidence. It's just kind of routine descriptive evidence. If you don't have that, does an intervention that relies on that evidence make a lot of sense? And so maybe you have to start off by developing a data system. This happens in public health all the time. Do we try to address a health issue when we don't have the surveillance system set up yet? Or is it, and that's really a type 1 evidence kind of thing. Can we even track the burden of a health condition? And so if we can't, then we probably need to think about, can't track progress, we better think about whether we have to set up that data system as a starting point. So I would say, Danielle, primarily it's sort of focusing on type 3, but the bleed over across these categories. Russ, does that make sense to you?
It does. And with that, maybe that's the point. You're mentioning audit and feedback. Ross, might be a good point to go to the next page, Victoria, if you would, about context. And the way that, at least I'm going to attempt to make that segue, is I think if we think about the evidence on audit and feedback, it's probably, in fact, I'm pretty sure it is, the most widely studied implementation strategy, or you could argue maybe it's a bundle strategies, but strategy. And what do we know about it? We know that overall, on average, it works a little bit, somewhat, but that's generally not very helpful. The question we need to ask about is, well, in what context? In what situations, for what problems, with what populations, and what setting does it work, and when doesn't it work? And so we place a big emphasis in this paper about context. And again, you're an easy audience for that, including some of you have taught us about this context issue, but we've tried to make this case again, realizing that it's a fairly broad audience, and we also want to influence not just researchers, put in the chat, and not even just practitioners, but also I think ideally funders and reviewers and that sort of thing too. So maybe pointing to the needs for more evidence on context on this page.
The interesting thing, and doing one of these papers, it can kind of go so many different directions, but in writing this and then getting some initial feedback from the editors, which is a whole different story we'll talk about a different day, but they set back some of these resources that come from other parts of the world, the MRC guidance that you're going to talk about, and so there's a lot of tools out there that we might not know a lot about in the US that we're trying to also bring into some of the thinking here. And so there's going to be probably as many that we missed as those that we found, but we're trying to bring those in a different part of the paper as well. Let's see if Amy's got a comment. Amy, do you want to state your comment?
Sure, yeah, happy to speak to that. So I think it's implicit in many places, but I don't explicitly see sustainability or sustainment listed. And you just mentioned we've been trying to think more about designing for dissemination and sustainability. So it might be worth thinking about where that could be called out. It's already kind of implicitly stated, but maybe just not explicitly noted.
Yeah, I think that's a great point. It's got little bits here and there, but it certainly deserves a focus. You can argue that it's one of the core issues in this whole field, and yet there's very little attention. It's sort of back to Dan's comment. It's sort of, we don't design for it early on. If you think about it, early in the process and what it's going to take to sustain something, it's a lot different than getting to the end of a grant or a project and saying, oh, now I'm in the last 6 months. Now let's think about how do we keep this thing going? And that's unfortunately how too often it happens. So I think that's a great point.
Yeah, good point. Shame on us. Thank you, Amy. We'll be sure and do that. And then related to that, I'm also looking, I know somewhere it's in the text. I'm having trouble going back and forth on things, but certainly the related and one of the key drivers of sustainment we know is cost and economic issues too. And I don't see us calling that out unless I missed it explicitly calling that out either, but certainly that related corollary issue. It's, as many of you know, we've spent last year a whole series of seminars and things on.
Yeah, that's great.
But thank you. Anything else? I want to keep time to get through this, so we still have time to engage Ross. He has to go at 3:15, so we can have general discussion. But maybe unless somebody has a point here, we could go ahead to the next page, Victoria.
Yeah, the equity one would be good if people see. So we just have two sort of broader recommendations, and then there are a lot of pieces of each one of these. And I don't think either of these is rocket science, but if people have any other thoughts of things that are missing around the health equity issue, I think we would all accept that we need to do more and better around this issue of health equity. It's sort of, what are the immediate things and what should we be recommending to this field related to the issue of evidence? So any thoughts about that would be welcome.
I wonder if it would be helpful to include some kind of like health equity theory or framework or recommend the use of one of those to help guide some of the work.
Yeah, that's a great point. And we're trying to work on a review of those right now. We've got a number of different reviews we've done of sort of the general D&I models and theories, but I think that would be great to build that out a little bit more. Rachel Tabak is working with a group and trying to lead that review. And the interesting thing about that review is, there's a small number that you would call sort of health equity, D&I models and theories, models and frameworks. The Ever Woodwards would be one of those. But then there's a larger group that are health equity frameworks that are out there that are applied to a whole range of different health issues that that wouldn't call them implementation science related, but there's a lot of relevance in there. So we're trying to bring in that group, which is probably a larger group, and to say, how could that inform, the D&I work? So thanks, Danielle. That's a good point.
This is Kathy. Just to piggyback on Danielle's thought, I was thinking of kind of standardization of also how health equity is reported and, can be compared across studies.
Yeah.
And it kind of fits into that same idea of maybe frameworks and stuff, but it's very hard even when you read studies to know how that, you can take some of that information and apply it to then what, your area of research.
Yeah.
I was just going to say, started typing in the chat, but I'll just say it out loud. It's just like within the health equity area, I think part of it is like, what is it that you're studying? Where are the gaps in terms of the populations, the methods like we have under 10, the emphasis on the structural factors. Part of that is not just describing the problem, but getting in and solving the problems, and all that. But the other part of it is just kind of the lens in which you see everything,
Mm-hmm.
So if you have a health equity kind of mindset, I don't know, Russ and Dan and I just wrote this mental models paper, but if your mental model doesn't include a lens to see these kinds of things, you're just not going to see a lot, So I guess I just kind of wonder, would that be something that would fit in here, just kind of looking at everything that we do with, a different conceptual model in our head, a different openness, a different, I don't know, just approaching it with a different way of being or something. I don't know. Yeah. I'm not articulating this all very well, but I hope that makes sense.
It does, Jody. The other paper we did last year with Shariki Kumaniki and Deborah Hare Joshua and Matt Kruder and I, sort of paper on health equity and implementation science. Part of what we were trying to get at in that, and I don't think we did it as well as you framed it, but was trying to get at this initial framing around health equity ought to be the starting point for every study. And so I think that that's an important thing and the interesting thing, I won't get too much on a side channel here, but when we first sent that to the journal, the immediate response from the editor was that we've been doing this for a long time. And I look back at articles and there were barely any this was in the journal Implementation Science. There were barely any articles that even used the term health equity. And even if you broaden it to all the other terms like health disparities, there were still relatively few terms, and so a few articles. So I think that our field has almost taken this as sort of implicit in what we do and not making it very explicit and not making it very focused. And I think that's really important. And Felipe, thank you for the comment in the chat. I saw that. We did try to bring in this idea of adaptation and actually some of your work that has been really helpful in that around sort of the sustainment and the cultural adaptation of different practices.
Thank you, Russ. I really appreciate that. One of the things in this field has been we inherited some of these major constructs like health disparities and equity and social justice that are really legal terms. They're very important macro level indicators. And one of the frustrations has been operationalizing them in a way that does justice to the intensity of those constructs, while at the same time allowing a more scientific and granular approach. One of the things that I think is important, like with health equity, it's such an important construct, but I think we need to start breaking it down into types of health equity and also consider process in health equity, in the sense that like health disparities, often the mantra is, let's get rid of health disparities. What does that really mean other than it's a high caliber goal? And so, but getting to the community level and practical implementation, conceptualizations, I think we need to get more granular. Easier said than done. But it has been one of the challenges, because these are great ideas, but getting it down to community level implementation, I think we need to operationalize them in some way, Although I know that when we do that, we decontextualize. So it's a real maddening conundrum. But I think we need to go there to some extent, because otherwise we talk about these grand ideas, but how do you really make a big difference, a big splash?
That's a great point.
Thank you.
There's a good paper to be written there. I think you should think about doing. Tina, do you want to, I see your chat. Let me see. You want to mention yours? I don't see you. There you, oh, there you go. Tina?
I am. That's because I'm hiding. I'm looking like for specific mention, especially if there's going to be a section about health equity kind of set apart from the others, about partnering with stakeholders or members of a population. And it kind of relates to Jody's comment about what the questions are that you're asking, but also the methods that you're using and the measures that you choose to use. And I'm speaking as someone who has recently been smacked down about one of my studies and who is on our team and who isn't on our team. And just thinking, you know, health equity, because so many people are, you know, it is a really important topic and a lot of people are seeing its importance and talking about it a lot, but that piece seems really important and it may sort of be referenced in other sections, but I didn't exactly see it like as a really particular method, because otherwise a lot, even though you've got the column that kind of talks about like who, what's the top of that column, who's responsible or who needs to take action on this, who the actors are, it's still very like academic, like there are researchers who should be thinking about health equity, but it's not really talking about partnering at all or purposefully incorporating the perspectives and knowledge and experiences of the people who we're supposedly, you know, trying to work with.
Yeah, and that could layer with what Felipe was talking about, sort of when you get down to the more granular level, how do you do this? Who are the partners? How do you engage partners? How do you get people where the academic stuff is going to be pretty irrelevant to their daily lives and make it real for people down at the, you know, basically how it affects someone's daily life and what matters to them in the daily life. So I think that's a really good point.
Victoria, why don't we go ahead and go to the third page, or excuse me, to the final page, whatever's next, and now would help. Thank you much. These are great comments, by the way. It's really helpful. Sometimes it's sobering to come back and look at this, you know, after you've been away for a month or two, the paper or whatever, I wonder, but very, very helpful comments, so.
So the last one, sort of the policy piece, and then this audience differences, audience segmentation, some of the ways we communicate science to different audiences. Those are some of the pieces that come into play here. And this is a little bit where the D4D stuff comes in down, but I think it comes in other places as well, but doesn't come through very strongly. So I think there's what we have so far, gang. It really was helpful, and there are several good points that we can incorporate as we go further. So this is sort of like rewriting a paper in real time and keeping these notes. And so Russ, I'll keep some of the notes for whenever we get this thing back and work on revising it.
Yeah, that's great. And Victoria's been helping us to record. This gives me a chance just to mention to others in general, too, that we are now recording at least the majority if the presenters are okay with it and posting these on the website. So if we want to return to that, if there's a key point or something, Ross, we can do that also. But some of these issues will come back in the next discussion, but I know Ross has to go now. So Ross, thank you so much for starting out your new year to
thank you. Happy New Year, everyone. Victoria, can you also keep the chat and send that to me?
Yes, I can do that for you.
Okay, that's great. Well, listen, good to see everyone. Everyone stay well and have a bright 2022.
Thanks so much, Ross.
Take care. Bye.
Take care. Okay. As we're going to transition to the BMC article now, but as we do that, just any other final reflections, things people didn't get a chance to get in? No. Well, we'll start with two things then, because I know I had the really bad form, Desi, to send you an article to possibly read over what's supposed to be time away from work and vacation. So at least half apologies for that. But I did want to talk about this relatively new article from the Medical Research Council in the UK. And you'll look at, there's two attachments that you'll see there. And Victoria, if you have up the PowerPoint presentation, if you could go ahead and pull that up, that would be great. But the rest of you can look at, you should have that. And then a holiday present of a 170-page document too for your bedtime reading that you have. And from that, I did an extract, one thing that has the full report, but I just thought it was the magnitude of the task that they did. I just attached that for two reasons. One, I thought it was just fairly impressive, and you can see the range of, you know, steps and people involved. But second, there's on page 170, I think, of 172, there's a table that they tried to boil this down into a checklist. And I will show you a little later. Victoria has a table of that, but if you want to look ahead or multitask, I believe it's page 170 or called Appendix 6. There's a bottom line after we go through this. There's of how do they think you can operationalize these approaches. But let me start with this. Again, please jump in here whenever if you have comments as I'm going through this. But I think I have about 7 slides that I want to go over. And again, I'm not very good at chat while I'm talking, so please others just jump in here forever. So first point, the reference is here, but I want to provide a little bit of context because I'm guessing that not all of you know about the Medical Research Council in the UK and kind of how it works and how it's similar and different from here in the US. It also, they partner a whole lot. They're a separate freestanding group, but they work hand in glove with their version, the UK version of the NIH, which is the National Health Institute Research, I think, NHIR, who actually commissioned this study. They have funding to go out and have different groups and provide guidelines. And unlike the cultural differences, unlike here, where kind of research and NIH is designed to be really separate, okay, from governance or policy or things like that, a lot of these issues are specifically designed that have policy actions and implications there. And in terms of a lot of the things, the valuation criteria, particularly the way they use cost effectiveness and other economic things, actually drives policy in terms of research there. The second point is that their earlier report, I think it was 2006, was the first, to my knowledge, discussion of complex healthcare interventions. Their definition, which we'll come back to and talk about here, was really, really influential, I think, around the world and formed a lot in particular of PCORI's. Laura, you might want to comment on this, including disagree if you do, but their conceptualization and their methodology guidance that they have too around complex healthcare interventions. Third, they did, whether you agree with it, and please don't feel pressured into saying that you have to or whatever, but they did have a huge number of steps and different people involved. Not many from the US at all, but from around Europe and a number of other different countries and a number of different steps that you can see there, from a gap analysis to expert panel to redrafting. And I'm guessing partially because of where it comes from, because of the breadth of involvement and the things there and the high profile publication, as well as this handbook that you have, I'm guessing that this will be actually fairly influential. Then my last comment there is that in general, this document, and I think this is in general from what I've seen, the UK, they do not make this distinction that we do between this line between an intervention and implementation strategy. And so I think a number of things that they're talking about as complex interventions, we might call implementation strategies also. But I'm going to pause there because that's my probably biased take on both just the background context and the MRC and the way it works. But let me pause here because I may well be misstating something or didn't get it quite right. So please, anybody else jump in here that either like to add to or correct anything I might have said.
I just have a question, Russ. So in the article that you sent us, is the framework that they're promoting this figure 1? That's it?
Yes,
right?
That's correct. Yep. And it consists of both these phases that you'll see there and then these core issues that are in the center that I'll briefly review. Yeah, that's what they're calling the framework that they had. And again, they see this as an update on this thing that you, I guess, 15 years ago now. Okay, any other initial comments or questions? Again, I hope that's right, or at least that's Russ's take, maybe somewhat only partially informed of the MRC, but I do like and refer you to take a look at their website and things periodically. I think it's quite useful. Okay, I will rip through the others much more quickly here. And again, you might want to look, if you have the article, the figure Jody was just talking about, I think is figure 1 on page 4 or something that kind of has it in a nutshell. But here's what we're going to do. And then I'll end up, this will be my last slide too. These are the issues here. They have a somewhat different concept of research phases, which is big. All of us have different ones. EPIS has one way, Roadmap has another one. They have different ones. So think about it. Core elements that we'll go over. That was kind of like the paper you just saw where we had our buckets or categories. And then just some thought questions for you, including alignment with the one we just talked about. But the bottom line is, after we go through this, you think it's likely you'll do anything different, or we should do anything different as a result of reading this article or not? So we'll come back to those, but keep those in mind. Okay, third slide, please, Victoria. Thank you. Okay, so just some quick bullet points here. I'm not going to read all of these, but they say this is taking off, and they're kind of changing, if you will, true north. Rather than answering what they talk about, what we call traditional efficacy research, as being the ultimate type of evidence they talk about switching that and going beyond asking if an intervention works to more understanding these more complex systems issues with the information for a decision maker as being, the ultimate priority and the focus here. It definitely has both a contextual, very explicit contextual and systems impact there. Third point is interesting, is that they argue they go way beyond where most implementation scientists do, where we're talking about cost or maybe cost effectiveness. They say you have to go way, way further downstream than this and be talking about overall societal impact, including things like non-healthcare implications. And the reason for that is that, again, they see this as being used to make important policy and funding for the country, not just for research, but for the country implications. I thought that was one thing that's quite different than the way that we do. Next to last point, they do talk under what they call program theory with the UK spelling there. It's where they talk about understanding how or mechanisms of change there. Next couple slides, Victoria, sorry. Switching out of my last meeting. So here's their phases. They have 4 phases that they talk about here. They're a little different. They talk about development and or identification of the intervention. And as I noted, often that involves adapting an intervention. A second explicit phase that they're almost mandating, as I read it there, although this will be interesting discussion, is they're almost saying they require a feasibility pilot study. Two other things that are more optional, but I think are intriguing, is that in this feasibility phase, even before you do a pilot, you should do what termed an evaluability assessment. And what they mean by that is it's just kind of a thought exercise to say, you know, would anybody really ever use this? You know, doing this in conjunction with decision makers. Let's say we did this intervention. Would anybody ever think about using it or uptake, even if it worked perfectly? And or using some predictive modeling, particularly some economic modeling at the outset, not just when you get results. Third, then the evaluation phase then. And again, they conceive of this as very broad, mixed methods, multiple outcomes. They do come back to this point we talked about last time about average effect size not being that much useful for decision making. And then they have a final, what they call implementation, which often I think we would call dissemination, and related to Elvin's term that I think you might have heard Ross use a couple times, transportability might use. I don't know if transferability was their term. I think it was, or mine, but that's what Elvin might call transportability to different settings. I'm getting tired of hearing myself talk. Let me pause there for a moment. I think there are just two more slides, but let me pause here so I haven't hopefully put all of you to sleep yet. Any comments, clarifications?
So do you think that they're intending, like there's arrows back and forth with all of these in the figure? So like you don't march through this and do one, then the next one, then the next one, then the next one, because it's not set up visually that way. You just kind of use them all interchangeably, kind of, or what do you think they mean by that?
I guess, I don't honestly know. It's a good question. I'm guessing that they would say, like we do, that there's in general sequence, but that they're iterative and they should inform the other ones. And so they don't want to get caught into this being a total linear model. Although my guess is usually these do, you know, follow in something like that. I'm guessing they'd give the caveat that came up that, you know, Dan brought up before, that you've got to be thinking ahead to the end stage, even in your development. But I think you're right. They wouldn't want to be put in a hole to say these are absolutely linear stages. Let's go to the next slide. Please bring up if you have any other comments or thoughts, suggestions. Again, as Jody said, please pull up. I didn't do a screenshot. I should have here of figure 1 that combines these, but here's the 6 points for their core elements that they have here that they think are important. Again, this is both for developing and for evaluating complex interventions. And they do explicitly talk about, just a couple points here, stakeholder engagement, with an important caveat that they have there, because they're playing very much for higher stakes than we are here. These things are going to have allocation and some budget resources. So they talk about not only the multi-sectoral engagement, but also being mindful of different conflict of interest that different stakeholders have and different perspectives, and just getting people from all different perspectives together doesn't necessarily solve everything. And so there are a lot of complex issues there. A fourth point there that I liked a lot was to try and be transparent or explicit about the uncertainties that you have there, and to working with stakeholders to identify, you know, issues, which is it most important to really get right, realizing you can't do everything or answer every question in every study, but what are the key issues here to really, where you really want to focus down, and, you know, what other ones can just be transparent to say, well, you know, we haven't studied everything and it may not apply in these cases. So with that, I'm going to turn to the checklist and then we'll have open discussion. The next slide. And I think I just want to show you, this is what it is. It is page 6. And I'm going to open it up for discussion. And then if you could, Victoria, let's just go to, you'll see these 6 points. The way it's organized, there are these 6 points that they have here. And then underneath them, they have a number of specific actions. And the checklist is arranged so it's kind of, you're taking notes on there. Do you say, have you addressed this? And then like where in your grant or your paper, you know, have you addressed it, and make some notes there. So let's go to toss up the questions that we have. It's kind of open-ended, but you might think about this. If you'll do that after people have a chance to start discussion, then Victoria, could I ask you after about 4 or 5 minutes to then go ahead and put up that final document that we have of this appendix that shows the 2 pages, but we'll have some general talk and then just go ahead on your own in about 5 minutes or whenever you feel is right to share that last document, if you would.
Okay.
Thanks. Let's maybe start with the second point about the core elements. We talked a little bit, Jody made the nice point, clarification about the phases, but what do you think about this notion of their core elements that they have? They're kind of saying this is the central issues, you know, to what we should be doing here as a field. Any quarrel with those? Anything missing?
I think, Russ, this is Dan again, just related to the same comment I made when Dr. Brownson was talking. I really like that they're including, they're calling intervention development research, and they call the development a phase of research. And you asked, would you change grants? And I don't know how many grants I have seen fall down because somebody was developing an intervention and they say, oh, this isn't really research, or oh, the second aims are dependent on the first aim. And I think that actually limits us in the ability to develop complex interventions, because then you have this pressure to develop your intervention before you submit. So if we could get a lexicon around that to where panels started seeing development as research, we could get more development funded.
Good point. Anybody want to follow up on that?
I guess I'd just say that would be great, because there's like no funding to do development. And so you're kind of forced into this corridor of developing something so that the reviewers have something to react to. And so if there could be some standards for evaluating the development of interventions, I mean, I think we're inching in that way, but it's, I don't know, I just reviewed something for, you know, another grant internally, and they were going to develop the intervention for number 1 and evaluate it for number 2, but it was like, I don't know what you're evaluating. So I'd rather just like rate your grant proposal based on how you're going about your development, you know, and then relieve you from having to come up with talking about how you're going to evaluate something that we don't know what it is yet, because it's hard for everybody. So I don't know what the answer is, but I like the reframing about thinking about that, so that there can be some development work done and be thought of as legitimate research.
Yeah.
But is that kind of apparent in the feasibility box? I don't know, because it seems like this group is saying that you should always include feasibility. And then they actually say refine intervention under the core elements. So maybe they're somehow developing it during that feasibility stage, which sometimes we don't always have in some of our
I was taking
grants.
Dan's comment more around the box of developing intervention over on the left, but
yep.
But you know, that makes sense.
I think both are true. This kind of iterative nature there. my reading of it. And again, I think the issue that y'all three made some excellent points here, I think is particularly acute if you want to get funded by the D&I study section. I think those of you that have been on it, usually there's at least a couple brawls or fights about beginning, well, is something adequately evidence-based? Is the intervention adequately evidence-based before you can even start? And a lot of, proposals get KO'd at that stage, even right there. And it is hard. I'm trying to think, it's been a while. I don't know if any of you on here have an R34 now, but to some extent, I think that's the only mechanism I can think of at NIH. I think other places that somewhat encourages you, but it's almost more of a refinement anyway to get ready for a large study, an intervention study, than it is starting initially from designing an intervention. But it's a type of, might be this feasibility box that they're talking about there. But I think it's a good, it's a good point. Any other reflections, comments on that?
Not on that, but I have to say, if you, the economic, like the scope of the economic piece that they talk about would make me so nervous to be able to find enough economists out there who want to help us with that.
Yeah,
or
it
have
is.
the bandwidth.
No, you're right. And almost all those issues, I probably get myself in trouble since there's I don't think any card-carrying economists with us today. I can't quite see who's come on or joined, but the ones I do know would say most of those issues are enormously complex, and there's so many assumptions that go in there and different perspectives and different timeframes, which is the other issue about when you're going to see who, when, and where do you have the cost, who, when, and where do you have the benefits, that come out of there, I think are, enormously complex. And I think that's maybe why we are, as a field where we are now, trying to learn enough about economics and partner with them so we can do at least a not too bad job of costing out, time and cost of delivering an intervention, and then maybe taking it to the next stage for identified effectiveness outcomes, what to do. But I agree. A lot of that, in fact, there are a couple of terms I wasn't even sure what they were talking about in there in terms of some of the types of economic analyses. What do you think about that? Is that just too much to ask, or did they get brainwashed by some economist subgroup that were on these panels, or do we really need to take this much further than we do now?
Seems to me that the stuff that they're proposing or saying is important requires like modeling. I don't, like most of this in the time frame that we have for our studies, these like downstream non-health related economic effects. I don't even know how good our data are to allow the modeling of those types of outcomes, because like you said, there's so many variables and interactions, and I'm not really sure how you would do it.
No.
I think as you're talking about health equity, or when I had my Addressing Disparities trial, I think, the more we could have talked about that in concrete terms and been able to measure it, the happier I would have been. We started out by saying we want to address a lot of problems in poverty, and it's a really complex intervention in some ways, and a very complex system in schools. And to think about, it's not only the change in that kid, but if the teacher is changing their language or whatever, what a broader impact that can have, in really changing communities of kids or families. And just kind of contrary to what you're saying, Tina, like I had to at that time include health impacts. It's an executive function intervention. I didn't really expect any health impacts, but it was Corey and they wanted that at the time. So I said, okay, well, they'll have fewer, non-urgent physician visits They'll use less medical care for behavioral stuff, and with absolutely no belief that that would ever come out significant, but I just sort of put it in there because I had to, in thinking about this broader impact, right? And we got an effect, much to my surprise. I mean, who would have thought? It was really being pushed to, maybe I should admit that so openly, but anyway, I think being pushed to consider these broader impacts could be, I mean, we don't live in the UK, right? So we don't have this, we don't have the advantages that would come along with that system. But, you know, thinking about those broader impacts to me is really exciting, even if they are hard to measure, at least considering them and hoping for them and shooting for them, I think is, you know, we should go forth with a little bit of bravery or conceit.
Oh, yeah, no, bravery. What's the phrase? You know, be humble in what you claim and audacious in what you attempt, or whatever to study is what you need to do to take it on. It would be fun if we had Deb Rutzwaller or Mark Greitz or somebody here talk about it. But I do think one discipline difference, I guess I'll group most of us together under one discipline of roughly behavioral science or public health or something, compared to economists, is they are generally much more comfortable with uncertainty or ambiguity or a wide range of effect size, rather than we've pretty much been trained that science is about precision, you know, and to really be able to provide a definitive answer. And that's even part of the discussion, if you read through the paper carefully, that they're talking about, where kind of this, it's almost a mental model change, Jody, that they're arguing, I think in our terms, away from, you know, kind of the RCT as that's going to define exactly, here's this point estimate of, on average, this is 28% better, you know, away towards this more contextual, you know, systems-based thinking here. So I think those do go together, but what I like of it, even though I think it's, oh, thank you. Somebody looks like Victoria found that. That's, I think, a little different than the one I was thinking of, but it's great. So I don't know if you can blow that up a little bit more, that helps. But what I like about it is this notion about removing these artificial barriers, you know, that we do have and tend to have here to make it, quote, clean, you know, between health and other aspects of society, school and health and government and, you know, other things over here, and to realize that impact. But yeah, it is kind of mind blowing when you think about the challenges of doing that.
Hey, Tina, one of the things I was wondering about as I was looking at your responses, the skeptic in me thinks about how decisions are made in the US and how political everything is. And it doesn't seem like at that level anyway, it's like the interventions or the approaches are kind of like, you know, here's the evidence and here's how much it costs and here's how much we get out of it. And here's, you know, like, it's like, oh, I need to do this favor to this lobbyist or something, you know, so maybe the UK is very different, but that's where I kind of like, okay, you want to run me through doing all this stuff. And then it's never really going to be used, you know, but maybe it does within schools or within healthcare institutions or whatever, different levels of policy, but it just kind of feels like you're doing a lot of work that no one will pay attention to, because a lot of people don't pay attention to evidence a whole lot either, you know? I mean, so it's just, I don't know. I'm sounding a little too negative starting off 2022 here, but I guess I'm just kind of wondering what their different context, if, you know, if you've got a national health system and you're really thinking about how you're apportioning out your resources and you know, that would be different than kind of what we have here, where everybody is capitalistic and going for different things. So I don't know. I think it would be great to do these things, but yeah, hard. So I don't know if that's what you
like everything that all of us do is great but hard. Just a different kind of hard.
The hard is what makes it good. Remember the quote from A League of Their Own. Because if it wasn't hard, everybody would do it.
That's right.
There you go.
See, that's the positive reframe.
Yeah, not that we want to totally romanticize. I mean, I think so many of the things, particularly the last couple of years, the inadequacies of our healthcare non-system have been so apparent, but I don't think we want to romanticize either. I think most people living in the UK would say that's far from a perfect system. It's itself there. I'm just trying to catch up a little bit on the chat here. But I wonder, Nikki, since you're on in particular, maybe I wonder if you want to expand a little bit on your point. I was thinking particularly about some of the downstream things and the time frame issues, and in particular, I should give you a chance to speak because I probably butchered at least 5 economic concepts that you could help us on when I was trying to address some of those issues.
Sure, thanks, Russ. Sorry, I got my little one here. Chat's a little bit, gotta be quiet, okay, bud? So yeah, well, the point I was just making, I had actually read a New York Times article when we were talking about the complexity and the downstream issues. I was reading this New York Times article this morning about how the choices we were making with COVID and the restrictions were actually choosing unvaccinated older adults over kids. And it had me thinking, well, it's the downstream effect. We don't, yeah, we're starting to see these things little by little, but these are kids, they'll bounce back. It's thinking downstream and thinking long-term. And a lot of times, I think it's difficult to know what to include in those economic analysis to know, but I think we can start to think about that. I think it's important to think about that. But in terms of the economic piece, you have to include those things in the model. And if you don't, you miss it. And so I think that uncertainty is the difficult thing about knowing, okay, well, what did restricting people from going out due to COVID, what were the long-term impacts or what were the downstream impacts of that? There are things that I'm sure we didn't think of or wouldn't have included in that model to know. So I think that's where the challenge is you don't always know what the uncertain factors are. And you can only include in a model what you think of and you don't, and you're not going to think of everything. And so I think that's where the challenge is that makes it really difficult. But we also could have known that, yeah, opioid use is going to go up in a pandemic. And, some of these mental health issues are going to go up. those are things that we could have thought about and included and considered. And I don't think we did at the time some of those decisions were being made. So that's the point I was trying to make. I think Tina talked about that some too. And so did Laura in their comments as well.
Mm-hmm. Mm-hmm. I think that just to following up a little bit more and others jump in here, I probably don't even know enough to get in trouble here, but I think this issue of time horizon or time perspective that you take is an interesting one. And this notion, there's, a lot of reasons and a lot of pressures that we have that what I think I usually see, especially in our country, is a really short-term time horizon. And that's somewhat understandable. Like if your group, your business may not survive past the next 6 months or year, that's understandable. But from a societal perspective, I think some of these longer term things are often lost. And I'm wondering, I don't actually know if there's explicit guidance or not, if it's buried in that 170-page document or not, that they use for that. But I'm just thinking, I'm pretty sure here, even in things like that the US government does anyway, I'm pretty sure there are some prohibitions actually from going out further than, I think it's something like 13 or 15 years or something to project a downstream thing. It's just that's not allowed by the Office of Management and Budget or GAO or something. And does anybody know more about that than I do? The basic issue is just that your answers to what you invest in change a whole lot depending on how far downstream you look, both inputs and outputs there. So. Let's see, I don't know. Rebecca, thanks or Victoria, thank you for sharing the model here. It's interesting, that looks slightly different. They have different versions than the one I think I was thinking of in the paper itself, but it has many of those many of those same points there that go around. Heather, do you want to say a little bit more? I'm just seeing your comment here.
Yeah, over the holidays, I was listening to this podcast called the Long Time Academy that covers, it's from England actually, and it covers topics like economics and politics and health and how we as a culture have taken the very narrow view, but there are societies that are starting to take the long view. And I found it really inspirational as in regards to our research and government healthcare and stuff. So if you're looking for a little optimism and positivity on the third day of a new year, it might be a good.
Hey, I think we can all use that. Very good. That's
and the neat thing is there's some bonus meditations in there to help you get in the zone if you're into that, which I. Oh,
yeah. All right. Yeah. Time perspective. Very good. Thanks for sharing that. That's great there. Hillary, do you want to say a little bit more coming back to this notion? I agree with you, this evaluability assessment. I don't know why it hasn't quite caught on as much. It's been around, to my knowledge, a long time. I think Laura Leviton, who used to be at RWJ, kind of started pushing it probably 25 years ago, but I don't know it's caught on that much in general. There may be other uses too, but I was interested in your comment. You want to just elaborate a little bit more about that?
It's new to me. I've never heard of it before, and I'd be interested in why it has not caught on. I think it's interesting because it's combining here stakeholders identifying what are meaningful outcomes. And I think sort of embedded into that, it can inform, what downstream economic, physical, social, contextual consequences or benefits should we be looking for? And I also hear a little pragmatism in here. Can we actually collect what we think is important to collect? I thought it was written into this paper in an interesting way, which is that it is very early on. It's part of feasibility. So if you can't evaluate what matters, maybe you shouldn't even move forward, which is a high bar. And then I was also thinking, similar to the economic evaluation, what kind of specialized skill set do I need to have to be able to do a rigorous evaluability assessment? I could see writing this as its own aim, or at least a part of an aim related to feasibility. Like if my overall aim was feasibility, then I could have this stakeholder engagement process to come up with something, in this, mythical unicorn developmental capacity building grant that we all hope to write. So why have evaluability assessments not become common?
I have no idea. I don't know. It's maybe, it's the thing about the right idea from the right person at the right time. Maybe it was the right idea at the wrong time, the wrong person or something, but I can see this fitting in, to this notion of feasibility, combining that with that of Dan's about the development and then having this. First, I reacted kind of negatively to almost this mandate that they have about feasibility. Like I usually push back about any of them, but as we talk through it, it maybe makes some sense, to early on just at least increase the chances that you're going to get it right through these pragmatic tests or things like that. My notion is, and again, Laura Leviton's the only one that I've read, and maybe one of you find out what references they cite there. I might not even know these references, but she really just talked about it. And I'm trying to remember, there's a colloquial phrase that's on the tip of the tongue I can't come up with, but it's kind of just like a kind of drop dead analysis or something you do with your stakeholders. Is just kind of, is there any way, here it is, in hell, that if this worked, that you'd ever think about using this? And it's just, it can be, I think, varying levels from just a real simple discussion to a pretty sophisticated modeling, exercise that's done there in terms of the inputs. But maybe
I could see it to be helpful because, related to one of Jody's comments before, sometimes interventions won't work because it's the not feasible right now with the current resources. But this thought experiment, this somewhat realistic evaluability assessment could say, well, but then potentially under these conditions, like if these contextual pieces also came together, or the other side, if these contextual pieces don't come together, like you're requiring too many resources to come together, so it's unlikely to work. Your intervention is too complex.
Yeah, no, good point. Let's all put down or do a little assignment. Maybe we can, somebody already has probably done a Google search or something, or a PubMed search to see about evaluability assessment, but that might even be fun to come back to and talk about. To me, where it's related, where our field, D&I, is going, is we're talking a lot about, acceptability and feasibility, and the UW group even has those pragmatic measures that many of you are using, those and things. But it's really, in a way, those could be thought of as a type of one aspect or part of, an evaluability assessment. So maybe more to be to come on that. Who'd like to have last word? No? We need Lawrence O'Donnell here. Any of you watch that? Why don't we wrap it there? I think that's a good note. Thank you all. Hope you'll have the article to refer to. We'll let you know what happens to the paper that Ross led, and I hope you'll find something useful, or at least have some resources from this MRC paper. And Happy New Year, everyone. We will see you at this time, same place, same time next week for some disco.
Bye. Happy New Year.
Take care.